As Tony said, I'm an injury researcher, and I have come from a very I've trained in public health, and really nice to see both Steve Leader and Bruce Armstrong here, who are really responsible for some of my very early training. And I have come out of a model really where I trained in public health and came from a context where we did studies, we did observational studies, and we did randomised trials, and we tested interventions in very clinical controlled circumstances, what we call efficacy studies, and then at the end of that we said, oh, we have to disseminate that, we have to get that out and tell policymakers about how to do it. But of course, we all know now that actually that next step is actually probably the most important thing, and really these efficacy trials really need to be embedded, if we're going to actually affect real change, actually need to be embedded in partnerships with the end users from the very beginning. So we should actually be having conversations with the end users as we design research studies, as we develop the questions, as we implement them, and have them involved all the way along. And so I think really when I think about my thinking about research over the last 20 years, it has shifted quite dramatically, and I think to some degree funding, say from the NHMRC and from ARC, has shifted somewhat in line with that. We now have research, we have partnership grants, but we've still got quite a long way to go before both researchers and also funders really recognise the models that we actually need to use in order to get research into practice. So, I mean, again, you've heard lots of different definitions, and as well, people do have lots of different definitions. There's lots of different concepts and definitions floating around, and I don't actually think there's any, there's no sort of gold standard, there's no sort of real answer. This is actually what it is. Research translation, though, of course, is it's the process by which we address the gaps between research evidence and policy. But as I said, it's much bigger than that. Generation of research evidence doesn't necessarily mean that we actually have changes in policy and practice, and we have lots of examples of that. I mean, you heard that from Tony. I mean, there's other great examples. I know some of my colleagues at the George Institute who've done large randomised controls in intensive care, looking at the use of albumin and saline in intensive care, and showing that really there's no difference, that saline's a lot cheaper, people should be using saline over albumin, but then actually trying to get the change in clinical practice is actually a really much bigger step than anyone would anticipate. And there's lots and lots of examples from clinical medicine around that. Research trials of intervention, so as I said, the efficacy trials, and that's really the explanatory trials, high quality randomised control trials, often give us no information about how interventions actually work in the real world. We might be able to say for falls prevention, that we've got, falls is a great example really, because we have lots and lots of high quality randomised control trials in very controlled circumstances, some more pragmatic than explanatory, but saying, oh, well, this intervention works better than this one, but we don't really know why, and then taking it into practice is another question. So we might be able to say strength and balance training is really effective at reducing falls in older people, but actually, how do we actually get people in the community to do strength and balance classes? How do we actually fund them? How do we get policymakers to fund them? What are all the barriers to implementation? They're actually the real questions that we really do need to start thinking about from the beginning. Now, that doesn't mean that we shouldn't be doing those efficacy trials in isolation, and sometimes it's really important to do that, but we really do need to have a much broader set of thinking around that. What I'm just going to do is talk a little bit about what implementation research actually is. And one of the things that I would like to really highlight is that, research and implementation shouldn't be seen as being the bastion of university-based researchers. And again, that research push that Tamika was talking about really comes from that context that, I as a professor of public health at the University of Sydney is somehow the owner of knowledge and truth, and that I will do research and then I will tell you what the truth is, and you as policymakers and practitioners will then implement it, and we'll have change on the ground. Now, that's the thinking that we need to shift. What we need to do, and implementation science and implementation research and knowledge translation and research translation is all about that. Is they're saying let's have partnerships between different groups of peoples and stakeholders, and thinking about what are the questions that we want to answer, and using research as a tool to allow us to understand what works and what doesn't work, and understand how to get that into practice. And really that's what I see implementation research and implementation science as being. It's about generation of that partnership and those research frameworks. So what is implementation research? And as you've heard, there's, again, lots of different definitions here. The study of methods to promote the integration of research findings and evidence into healthcare policy and practice. Really, it's about a systematic approach to understanding and addressing barriers to effective and quality implementation of health interventions, but also strategies and policies. What's really important, as Tamika said, it's actually demand-driven. The research questions need to be framed based on needs identified with the stakeholders and implementers, not coming just from researchers. And that's really, I think, the most important point that we need to take out of here. It is a type of health systems research, and there's lots of different facets to implementation research. And I'll show you a diagram in a minute that sort of highlights that, but it does build on different types, so operations research, participatory action research, management science, quality improvement, implementation, impact evaluation, and all of that within a good, strong public health framework. So we've also have epidemiology and public health methods within that. It does require flexible designs, though, to account for the different contexts and interventions that we work. So implementation research can actually be very simple. It can actually be focus groups and in-depth interviews with stakeholders to understand challenges to implementation or uptake of certain strategies. It can build on efficacy trials and pragmatic trials and effectiveness trials and really high quality randomised controlled trial designs in the community. It can be much more complex than that. It can be about specialised analysis or interrupted time series studies, looking at, and it depends on the questions that we're asking. So again, I don't really expect you to see this, and I'm going to give you a list of resources at the end so you can go and look up all of these different resources that I'm referring to. This is from implementation research in health. Again, it just sort of shows you the different aspects of the research framework within implementation and where it sits. So right down the end, implementation not relevant, we get the sort of blue sky research basic science. Right up the other end, we get research where we have implementation as the primary focus. And some of the examples listed down there: mixed methods and quasi-experimental studies to determine changes in delivery or acceptability of a program. Midway along here, though, we see pragmatic trials, we see effectiveness trials, and it really just depends on where we are along the implementation pathway as to the research methods that we use, and we often use a combination. Some of the characteristics of intervention research are these. So systematic. It's systematic. We do need to actually use a framework. We need to make sure that the work that we do with implementation research and research translation is systematic. And that's so that we can share it with others, actually having a framework where we can document methods and that we can report on them. And again, that doesn't necessarily just mean in the peer-reviewed literature, it means through meetings, seminars, and all the other things that Tamika was talking about. It tends to be multidisciplinary with collaborations between people with different backgrounds. Contextual, demand-driven. As I said, framing research questions based on needs identified by the implementers in the health system and other stakeholders in the community. It needs to be reflective of the local circumstances and the context. It needs to look at what the different circumstances are in each situation. It can be based on very small scale in small communities or small issues in particular areas, or it can be large scale looking at systems level across a state, for example. And it does tend to be complex, but it can be simple within that. Some of the kind of questions that we might be asking within an implementation research framework might be these. What are the effects of introducing and scaling up a new component? What lessons can we learn from other initiatives? Obstacles to scaling up the intervention. How will stakeholders be affected? How are they disposed to scaling up? How do different strategies work for dealing with the different stakeholders? And this is where we really get into understanding how do people actually implement things and what are the barriers and challenges to doing that, addressing that in a systematic way and sharing that information. What are the projected costs of scaling up? Again, these are the kind of strategies that can be used to improve implementation in health. And these are strategies rather than program elements, but these are things that we actually evaluate within implementation research. So you might have a program that's aimed at actually, say, reducing fall rates in the community, but we need to have strategies to get those programs out in the community. And so partly we might sit back and say, well, what other things, how do we actually evaluate those strategies? Some of the strategies might be from government, from implementing and provider organisations, individual providers and frontline workers, communities and households. How are they impacted? What are the strategies that we need for those people? And there are multiple actors across all of these. Some of the outcome variables that we might look at, again, are a little bit different from what we might generally use in, say, an efficacy trial. It might be about acceptability, the adoption, appropriateness, feasibility, fidelity, cost, coverage and sustainability. These are all questions, and again, I'm speaking to you as policymakers, but these are questions that researchers often don't actually think about, but they're things that you think about all the time, so it's bringing people together to actually get these questions embedded in a research framework. I'm just going to talk to you now, I'll just give you a couple of examples of some of the work that we're doing, and Tony had asked me specifically to just refer to some of this. I've done a lot of work in road injury, and because of that, and because a lot of the change that's affected in road safety and road injury is actually legislative, we actually have to communicate with our stakeholders very closely very early on, because most of the implementation and evaluation is done by our key partners in government, so we tend to develop relationships very early on. I do also have a big program of work in Aboriginal and Torres Strait Islander injury, and again, much of my research is informed by, I guess, best practice in that area, which is that to start working on research with Aboriginal communities, the questions have to be defined by the community, and they have to be articulated by the community, and they have to be key partners straight away. So we are actually working with the community and the policymakers straight away to actually understand what the research questions are and to understand how to implement effective programs. Driving Change is a big program that we're running at the moment. It's a licensing support program for young Aboriginal drivers. There's lots of barriers to driving for young people in the community. We've got very tough graduated driver licensing laws. For young disadvantaged people, actually getting a driver's licence can be very tricky. And it can actually, if you can't get a licence, it often leads to a cycle of disadvantage. People get fined for driving without a licence. They have problems with debt so that they can't actually get into the licensing system to start with. And we also know that licensing is strongly associated with employment and education for young disadvantaged people as well, because it's seen as a ticket. It's actually a qualification in itself. So this program of work started. We'd been working with Aboriginal communities just around road safety for quite a long time, and just sort of looking at what are the issues. We know Aboriginal people are overrepresented in road crashes, but it came very clear over the years that actually the road safety issues were an important issue, but actually driver licensing and barriers to driver licensing were a much bigger issue and much more important to the community, and it was a sort of untouched area from a policy perspective. So these issues were identified, and we did have a study that was an ARC funded study where we actually did surveys of people in the community, which was really aimed at road safety more than anything. We did a lot of qualitative research, focus groups with clients, and also in-depth interviews with stakeholders. So these are Aboriginal, we interviewed Aboriginal people in attending Aboriginal community controlled health services in New South Wales and South Australia. A program was then developed, and that's been informed by both formative and process evaluation. From the very beginning, though, with the development of the Driving Change program, we've actually had partnerships with the Aboriginal community organisations that we work with, but also the New South Wales Government, so both Roads and Maritime Service and the Centre for Road Safety, but we also have been directed by a steering committee, which has got Aboriginal policy makers, I guess, from Aboriginal Affairs and from all the other key government agencies, including Justice. We've worked with the police and a range of other agencies. So we've been having these meetings quarterly for something like 3 years now, and that steering committee has very much directed both the development of the program and the implementation and the evaluation within a sort of translational research kind of context. And the program's being implemented across New South Wales at the moment, and there's impact and outcome evaluation, and the outcome will be a controlled time series evaluation, but there's lots of other assessment in there around barriers to implementation, the fidelity of the delivery. We're looking at cost and also looking at it from the perspective of the young people involved in the program. Other work that we're doing is on falls in older Aboriginal people in New South Wales. And again, the issues have been identified from data and the series of studies, but also linked data analysis of hospitalisation data, also audits of services across New South Wales, and yarning circles with Aboriginal people. We've had Aboriginal staff running these focus groups or yarning circles with there were over 80 Aboriginal people across New South Wales, and then a program was developed with, again, the input of community and policy stakeholders. So again, this study is actually directed by a steering committee, an Aboriginal steering committee with people from Aboriginal community controlled health services, but also from policy makers, and very closely with working with Lorraine Lovett from New South Wales health. So the program's been developed, overseen by the steering committee, and then it's being piloted in 4 or 5 sites with very, very detailed evaluation. It's got a pre-post intervention, but we're looking at acceptability, fidelity and delivery, and then the next stage, of course, will be taking it to some kind of efficacy and hopefully effectiveness trial in the community to look at whether it actually reduces falls and the implementation challenges and costs. So in that way, we're actually doing this kind of research. It's embedded within a research framework, but there are a lot of different questions, and obviously we will also need to look at scaling up. This is a great opportunity for a partnership grant, so if anyone out there from a local health service wants to actually partner with us on this, we will be looking for partners. There are other work. Kathy Sherrington at the George has been doing work on falls programs, and again, implementation research funded by New South Wales Health, I think, and they were characterising the content and delivery of the physical activity programs that include falls prevention that are funded and supported by area health services. And within that, they aim to actually look at what was actually happening. So we know about the effectiveness of these programs in very well-controlled trials, but she actually, and New South Wales Health, I think, wanted to actually look to see how were they being implemented in the real world and what were the recommendations and barriers to actually uptake. So they reviewed a randomly selected sample of classes, they observed them, did staff interviews, including the assessment of adherence, transport, cost and structure, and then made recommendations about the content. And that has gone back into the Active and Healthy New South Wales Government website, both for the development and the inclusion criteria for programs on that. She's also running a pragmatic, another trial, which is basically a partnership with the Illawarra Shoalhaven Local Health District, which is the local health district developed and pilot tested a cheaper way to teach older people to undertake the Otago exercise program. So the partnership program is actually looking at the effectiveness and cost effectiveness, but also the feasibility and the appropriateness of scaling the program up. And these are the 2 designs that go into this. This is an NH and MRC partnership grant. We have effectiveness study and cost effectiveness study, and so we've got a big pragmatic randomised control trial, but the second stage of it is the feasibility and appropriateness and the scale up. So in-depth interviews with all the stakeholders and trial participants with a process evaluation to look at the fidelity and so on. David Pearce has also been doing, he's got a lot of implementation research underway, and one of the studies is the consumer navigation of the electronic cardiovascular tools. And again, it's a consumer-focused e-health strategy. Many of you will know about this program of work, but the intervention was developed via a sort of user-centred design with all the different aspects, workshops, diary studies and consumers and pilot testing, and then taken out to a pragmatic large-scale study in general practices. So again, they're just some examples of some of the kind of work that you can do. But of course, there are many other examples of research that are people doing, and a lot of this work has actually been driven by the policymaker rather than the researcher, and it is about that kind of partnership. If you aren't aware of the partnership grants, NH and MRC partnership grants are really aimed to do this, which is actually looking at uptake and evaluation of interventions, and it's a really good opportunity, I mean, again, for local health districts to actually get some funding into evaluating some of the programs that you might want to see and looking at scale up, because if you can provide either cash or in-kind support, then you will, and you partner with a research organisation, you'll be able to actually get really great leverage on your investment in that. So that's certainly worth talking about, and I think that's one of the things Tony's quite keen on doing, is actually trying to broker partnerships and relationships between research groups and local health districts so that these kind of projects can become more feasible. These are just some of the resources, and it's worth having a look. The Implementation Research Toolkit's great. Have a look at the NH and MRC Research Translation Faculty on the website for the NH and MRC, and there's a couple of other resources there for you. Thank you.